there are 2 billion medical decisions made every single day across the world. Well, on average, each clinician makes about 100 decisions a day. None of those decisions are made in a vacuum. They're made in context, in a healthcare system, in a hospital, in a pre-hospital environment that is extremely complex, that's patient-specific, and that's hospital and site-specific. You need knowledge from two sources to make decisions. The external knowledge is journal articles, national level guidelines, NICE guidelines, medication knowledge bases, etc. The other one is the institutional knowledge, all of that information about how do I work in this hospital, what can I do and what can I not do. Both of those problems need solved. Eolas solves both of them. The barrier to accessing knowledge and medical knowledge should be lower and lower. The more people that can access it, the better it is for patients.
Declan, founder of Eolas Medical. How are you, sir? It's been a while.
Nice to be here, James. Thanks very much for having me on. Keeping well. How are things?
Well, things are good, man. Things are good. I can't believe that you've not been on this yet. It's that's a massive oversight on my part that you've not been on. So, looking forward to this, man, because I know your story, but I think there's nitty gritty in there, particularly in your background that I might not actually know. So, looking forward to getting into it. And I think where Eolas Medical did fit into the world is very different to where it fits in now. I think I don't know if you feel this as well, but you were ahead of your time, because the world has moved on to a place now where what you're talking about and have been doing for a long time, which broadly in knowledge management and decision support has become quite, it's an au fait term. People are fine with it now, and they perhaps didn't used to be when you came up with this idea and did a shed load of work behind the scenes on building the infrastructure. So I think it's a super fascinating time to be chatting to you and to figure out where Eolas fits in. But before we move on to that, let's just talk about you and your story. So where does this all start for you? Where does becoming an entrepreneur fit into your journey? Have you always been one? And why healthcare? Why Eolas?
Yeah, 100%. No, and yeah, I'm a avid listener of the podcast over the last number of
You
years.
don't have to say that, man. It's okay.
No, I am. Yeah, it's up there. It's up there on the.
And I know you are, because you text me sometimes as well, and you're like, "Oh, it was a cool episode, man." And I'm always like, "Oh, there's actually people that listen to this. That's really nice."
Yeah. No, exactly. No, yeah. Thanks for having me on. Great to be here. So I can give quite a bit of a background and an introduction on that side. So yeah, so I'm Declan. I'm a medical doctor by background. I worked clinically in the NHS for about 5 years. I'm also a software engineer as well, and I suppose that's really intrinsic to the story. I think as same as most people, it was finding a problem that you faced when you're treating patients that was difficult and frustrating, and I think combining that then with looking at software and how software can solve that type of problem, just it was really the seed that led me down this path. And I suppose if I touch very quickly on that problem in general, so when you're treating patients, it's very difficult to find the information or knowledge that you actually need to use to treat that patient. And we did a bit of research on that initially, and we found there are 2 billion medical decisions made every single day across the world,
Whoa,
give or take.
Okay.
Yeah, so on average, each clinician makes about 100 decisions a day. And I think that the most important thing about that is none of those decisions are made in a vacuum. They're made in context, in a healthcare system, in a hospital, in a pre-hospital environment that is extremely complex, that's patient specific, and that's hospital and site specific. Like very, very quick example, STEMI in resus. How do I activate the cath lab? What do I actually do? What antiplatelets should we use in our hospital? So all of that stuff is really important to know.
This really resonates with me because I, like so many people back in my day, did an F3 year where I just locumed around A&Es in London, just picking up whatever shifts I could, basically, to earn enough money to go traveling then for a few weeks or whatever. So great year, great time to be doing that stuff. But the problem that you've just described was so anxiety inducing for me, knowing that you were rocking up to a brand new hospital, brand new A&E, and not knowing that basic stuff, like where do they keep the cannulas? How do I send someone to get, like, all of that stuff is, it used to honestly weigh on me. But then I also had it in my own training as well, because when you move jobs and you rotate, and especially, the back end of F1 and moving into F2 and all the rest of it, like, you sort of expected to know quite a lot of stuff. And my first rotation was psychiatry. So then when I rotated into my second ever job in medicine, it was just so expected that I knew so much of what you've just talked about, like how the hospital works, that I actually just didn't know because I hadn't done a cannula for 3 4 months and had only probably done one at medical school. So then I was like utterly fucked. So
Yeah.
yeah, no, I get it, man. I get it. And it's crazy. It's crazy that we that we existed through that world and now here we are able to solve it. But please continue.
Yeah, no, 100%. I think you're just kind of expected to know this and pick it up very quickly and extract that knowledge from other people's heads that have been there and done it. And I think to that point, to put a few figures on that of the point that you just made, um, about in the UK, about 45% of doctors are either training or rotating doctors. So that means that either every 4, 6, or 12 months they're moving from one department to a new department that they don't have a clue how to work in. On top of that, 15% of staff are now locum staff. So you've almost 60% of staff potentially that are moving from one department to another or one hospital to another,
Interesting.
and that changes significantly. So what we try to focus on is the internal institutional knowledge that all of those doctors need access to. And if you think about, kind of frame it through the lens of, okay, as a doctor or, a healthcare professional in general, you need knowledge from two sources to make decisions. One is external to your institution and one is internal to your institution. The external knowledge is journal articles, national level guidelines, NICE guidelines,
Yeah.
medication knowledge bases, etc. The other one is the institutional knowledge, all of that information about how do I work in this hospital, what can I do and what can I not do. So both of those problems need solved. Now, Ola solves both of them. We aggregate external knowledge and bring that onto the platform. That is a space that's a really interesting space, but it's ultimately becoming commoditized, and that's a good thing because the barrier to accessing knowledge and medical knowledge is should be lower and lower. The more people that can access it, the better it is for patients. So you have now companies in the US like Open Evidence who now license JAMA, New England Journal of Medicine,
Mm.
etc. They train and fine tune a model on that and give access to that. You've about 100 YC companies, doing that in the external knowledge space. OpenAI, Sam Altman is 100% making deals with JAMA and New England Journal of Medicine to get that. So doctors are going to be able to get that external knowledge from anywhere, which is really important. So that's ultimately table stakes now. What they can't access is the internal knowledge for their institution. In this hospital for this patient in front of me, how do I actually treat them? And that's what Olus hyper focuses on. It's the knowledge that doesn't exist anywhere else, and therefore will only exist in one single sole location. And I think, back to your original point of we're ahead of the time is such a thanks very much for that. But I think we were more focused on this is a problem that we have. Let's solve this problem. I think the big shift that's happened obviously is a
Yeah.
technology
Okay.
shift. It's become much easier to solve that problem and much easier to reduce time to insight. And that's what large language models have done. Historically, we launched this before large language models come into the mainstream,
Yeah.
and we were looking at graph databases and we were looking at the ability to extract knowledge from all of these complex flowcharts and diagrams and documents, and how do we represent them graphically so that a user can ask a question semantically and get an answer very, very quickly. And you're trying to represent knowledge, you're trying to re-represent it in a way that's not in its original form. So the original form is text. And that's the ubiquitous way of how humans have represented knowledge historically. The problem is trying to convert that text to a machine readable format has been impossible up
Mm.
until 2022. That's the fundamental shift that has now happened. The ability to build and distribute that knowledge in a way that's actually safe and effective is now really taking hold. And that's, I suppose that's
Mm.
the why this has been brought into the fore. But
Mm.
this is an area people have been working on for decades.
And it's becoming more important, isn't it? Because I think we're going from a world where you wouldn't necessarily instinctively trust the signal, the output from such a process. We're now moving into a world where there's no choice but to trust it because of the fact we're using this stuff in all aspects of our lives. And it's the direction of travel, isn't it? That clearly we're so used to using this everywhere else that it's going to be used. It's sort of like the WhatsApp conversation, isn't it? Like, look, it's going to be used. We're just going to have to find a way. And then the companies pop up to try and find a way to do it. It's sort of similar in that kind of knowledge support using large language models. Like, ultimately, this has to be done right. It's going to happen anyway. Um, I'm interested though, man. Like going back a bit earlier in your journey, were you a software engineer first or a medic first? What was first for you?
Yeah, so medic first. So I did a lot of coding and engineering during school. So in high school actually. So
Huh.
I would build things on the side and
Why? What? How did you get into that?
so I suppose I always liked I liked the hardware aspect as well as the software. So I used to
Okay.
always like taking laptops apart
Yeah, and
and
building them. Yeah.
putting them back together, and oh, there's always pieces left over. But that was the fun of it more than anything. And I was always just I think it's just from an engineering point of view and a problem solving point of view. It's just like a big
Mm,
puzzle, where like, regardless if it's hardware or software. And it's quite addictive as well. Coding and building things and seeing things something go from a blank screen to something that's able to solve a problem is it's really enjoyable. It gets you into a flow state. And so I've always kind of had that. They're always really interested in that. But ultimately didn't do computer science, went down the medicine route,
mm,
graduated, worked clinically for about 5 years, mostly in emergency medicine, and then it was always coding on the side, though, building different things, just to keep the interest kind of alive.
mm.
I very much was, hurtling down the path. I wanted to do dual training, so I was in emergency medicine training, and I wanted to do dual training in ICU, and I really loved the medicine aspect. And it was only really when I started coding a platform for our own hospital to solve this problem that we were chatting about. And within about 6 months, the platform that I'd built was used in 28 hospitals, including Stanford and a few others.
Wow.
So it was kind of at that point we realized actually this is a pretty ubiquitous problem. People are finding this as an issue. So because it started scaling to other sites, I had to reduce my time down to half time clinical, half time in the business,
Yeah.
and then I had to jump in full time to continue scaling that. So I suppose that was the kind of origins of it.
I have quite a specific question now around the practicalities of that scaling and how you then turn it into a business, or were you giving it away? And I'll give you a bit of a case study here. So vibe coding is now a thing. People can go on Lovable, they can go on others, they can build something, like they can have an idea to what you're talking about. They don't necessarily need to be a software engineer. That's quite an exciting time. And let's put security concerns and other things away for a second. But someone who was previously a medic that could only spot problems because they weren't a software engineer can now kind of build it and go, well, now I've got an actual working prototype MVP. It's kind of working. It can do a thing. Um, and I guess that's the position that you were in initially. Now, were you coding that for the hospital you were in for any kind of commercial reason? Because other people could be doing the same now and they could be thinking like, well, how do I turn this into a business? Do I charge my hospital for this? Do I use my hospital to check that it's working and maybe charge the next person? Or how do I even do that? How would that work with my medical training and salary and like all that sort of stuff? So what can you just like zoom in on that bit for me when you did it and what was going on in your mind and what was maybe difficult or not difficult about that based on, I imagine at some point you had very little business knowledge and now you have a lot. So yeah, what was that bit of the journey like for you? Because again, the reason I ask is I think there's probably a lot of people in this boat increasingly because of things like vibe coding.
Yeah, 100%. So so much to dive in there.
Sorry, quite a big
Yeah,
question.
yeah, no, because there's a lot of really interesting trends that are happening. So I think fundamentally, bringing it right back, fundamentally you have to start with the problem, and you have to have a really really deep understanding of what's the problem you're solving, who are you solving it for, and then if you want to think from a commercial or business lens, how big is that problem? How many people does it affect, and how big a pain point is it from a time, money, or patient safety issue, essentially. And I think that's really, really important. That's the starting point because technology trends will come and go. Technologies will evolve and they'll move and they'll shift and they'll change. Yes, it's definitely easier to build, but it's irrelevant what you build if it doesn't solve a problem and you can actually prove that that problem is actually solved. So I think that's the thing that's I think that all of the noise currently in the space is at risk of getting lost because just because you can build something now within an hour doesn't mean you should build it. And you need to actually understand what the problem is that you're solving because as you said, it hasn't been easier ever to build an app. And I think that's getting better and better. initially, over the last year or two, they weren't that great. Now that Lovable has launched their back end
Yes.
service, it's getting a lot better. So you can kind of start to see where a full stack application comes. There's a lot of other skills needed to build a full stack application with regards to obsessing about the problems, being product focused, and then in a healthcare environment, understanding how all of that tech works and proving how that tech works after you've kind of built it. I think we're a very long way away from a vibe coded product in healthcare being used in production across multiple sites. I think we're a very long way away from that, which is, it's good that healthcare technology is a double-edged sword. It's very, very hard to get in, but once you're in and you prove the value and use case, then you become very sticky. Um, and the reason for that is, I think you've covered it loads of times in the show, and other people have covered it. You have the patient safety issue, you have this cybersecurity issue, you have all of these issues. What it's very good for is testing an hypothesis of the problem that you want to solve.
Interesting.
That's really what it's good for. So how you would test this hypothesis 5 years ago is you either code it up yourself or you put a slide deck together.
Mm,
You talk to your clinical director or the director of the hospital and say, hey, here's a big problem, I think. Here's how big I think it is. What do you think? I should do a project in this, or I should develop something out, etc. And then you have to convince someone with a PowerPoint presentation. It's much easier to convince someone if you show them something. And if it's just as quick to show them a MVP than it is to put a slide deck together, then the barrier to convincing someone
yeah.
is much, much lower. That's only the first step. You then have to do everything else on top of that. And where the tools are right now, you probably have to bring in people to ensure that they're safe from a cyber security point of view, that they're safe from a clinical safety point of view, etc. So we're a long way away from jumping from that MVP to that actual product that gets deployed in
Mm,
healthcare.
mm.
So yeah, in summary, I would say obsess about the problem and think about what technology you use to solve the problem after you're very confident that that problem needs solved.
So when you did this, did you initially build it for your hospital with a business in mind, or did that become apparent once it had moved places for free?
Didn't build it with a business in mind initially. So I built it just to solve a problem, and then a hospital, down the road wanted it as well, and then I started charging a small amount, ultimately to cover costs. At that stage, I was still very much like, this is the path I'm on. I'm going down this path from a cleaning, training, and clinical point of view. And it was only when it started getting into more departments and we saw the opportunity and the kind of the bigger problem needed to be
Mm,
solved. It was like, okay, well, how does this scale? How do we solve this problem for as many people in the world as possible? And I think, yeah, I think that's when we started wrapping a business around it. Um, I suppose I got lucky in a way in the fact that the very, very first thing I did was join an accelerator. So I know you've led and helped, digital health
mm,
accelerators before, and there's a lot of them. This was a vertical agnostic business accelerator that was based in Belfast, and so it was run by Invest NI, and the team there were sensational. So I jumped in with very little business knowledge, and within the space of 3 months, we're able to upskill on scaling product, raising venture capital, how to build a team, etc. So all of those things. And I think that was really important to set me down that path, because if I jumped in too early, I would have made a lot more mistakes. So I think find a community is the thing that I would say. Because you've so many unknown unknowns, and just immerse yourself in that community as quickly as possible, at as early as possible, is the key. I think people are generally very helpful, and people like to see other people coming through with ideas.
mm.
And if someone's seen it and done it, like even me now, looking back over the last 4 years or so, I'm I mentor a lot of people. I'm very, very happy to jump on calls with people, and so that they don't make the same mistakes that I do. Also, specifically in the healthcare space, I really like doing this, because I think
Mm.
the more competition that enters this space, the more people that are building, the more clinicians and healthcare professionals in general that are building, the better the entire ecosystem becomes, the more problems that we're able to solve for patients and for healthcare professionals. So it's only a good thing the more people that are entering this space and building, but they have to do it in a proper way, or else they'll
Mm.
stumble and they'll fall, and they have to engage with the right parties to do it in the right way. So yeah, find a community would be the big.
The timeline of that's really nice because you built something of value. You got so many signals from the market, it had value, and you were learning at the time. Then I think the thing worth pulling out here is about accelerators, just very briefly for people. I know I've covered this a lot, but when you're picking an accelerator, you have to just find one that's going to give you what you need. Not every accelerator is going to be a fit for everyone. And accelerators get a very bad name, I think, because of this quite a lot, that people go in with certain expectations and they're not met because they're so unique. And I think for someone that doesn't have business knowledge and is looking for that kind of earlier stage stuff, there's accelerators for that. If you're looking specifically for market access, there's stuff for that. If you're looking for a co-founder, there's stuff for that. So it's finding and mapping what you want from those support mechanisms, rather than just hoping that generically applying for a load of stuff looks great for you and you're more likely to get investment. It doesn't really work like that. But what my next question, mate, is what was the product at that point? The product that you initially built, and when did you build it? When was this?
2020, when I had that initial product launch, the very first MVP
Yeah.
into the hospital system. So I was still working clinically. It was still very, very early stages, and the very initial iteration of this product was in our department. How do we manage all of our policies, protocols, our internal tacit knowledge? I have someone has a DVT. When do I get them for their ultrasound again? Is it 2 days? Is it 7 days, etc.? All of that stuff that you just needed very
Mm.
quick access to,
What was
as
the
well as
front end of
education.
that? How was that accessed by people? What did it actually look and feel like?
Yeah, so mobile and desktop platform.
Interesting.
So 70% of users are mobile, the rest are on desktop. But most of it was mobile, and then there's the admin side. There's a content management side where all of the admins would add all the content. So it was the two aspects. Yeah, so I coded it up in Java for Android for any
Wow.
engineers
Okay.
listening, and that was a mistake. But it was
Why was
very
that mistake?
fun. Java is just an awful language,
Okay.
and it's just horrible to work with. And they probably should have chosen an agnostic platform. So
Why
I
did you
used
choose
Swift
Java?
because I did the iOS first, so I chose Swift for iOS,
Right.
and built in that, and then because I didn't use a cross-platform language initially, I had to use a native language for the Android, so I had to choose either Java or Kotlin, and I chose Java. It was about like 6 months to build the whole thing, and it was torture, but it was good learning curve. And then once I actually raised some venture capital money and hired engineers who are much better than me and know what they're doing, they're like, "Why don't we just build this using React Native and across platforms?" So we shifted over to JavaScript and use React Native now. So, but yeah, I think if you a bit of background for coding in Java is a good thing to teach you the right principles as well.
Nice. Okay, so walk me through the journey next then. So you've 28 hospitals you said it scaled to. Where does the investment come in, and where does the scale of the company go in that story?
So I suppose there was a window there in which I was developing COVID related tools as well. So I was helping
Oh
develop
wow.
tools to see if we could triage patients faster. So I took in all of their sats and their vitals and everything, and then
Mm.
tried to predict would they end up being admitted, would they end up going to ICU, or could they be safely discharged, etc. So I built this whole prototype. That was a very good lesson, because it got to the point where it was like, hey, if you're building a clinical decision support tool that manages patient data, it's very, very difficult to get it into a hospital very, very
Right.
quickly. So that was a very good learning point. So we never actually went live with that, and I spent about 4 or 5 months during that, building it, working with some of the emergency departments to
Wow.
do that.
Wow.
But it was still very useful from an exercise from that point of view, and learning all of the inputs that need to go into a clinical decision support system, as well as what does regulation look like, and then all of the inputs that need to go into what does a patient data system need to have from a cybersecurity side of things. But yes, but ultimately we almost went live in an emergency department, but we didn't actually use it. So there was a window there where I was just doing the COVID side of things. So it was 2021. All of the hospitals were still using the platform, and at that point, I was on the accelerator, and we made the decision with some of the mentors that this is probably a venture backable company. There's, as I said, billions of decisions made every day. There's about 50 million healthcare professionals globally making these decisions, and they can't access the information that they need.
Mm.
There's a model here for building $1 billion business. So we raised venture capital in 2021, so June of 21. So it was just myself. There was no one else in the team at that stage. We did a round of 2.5 million
Whew.
as a pre-seed round.
As a
Um,
pre-seed,
as a
wow.
pre-seed round. So this is nothing to do with me. This is 2021.
I was
peak
going to say, what a time to be
valuations.
raising money, man.
Yeah,
Honestly.
yeah, yeah. So, and I think as a double-edged sword, I think valuations were far too high at that stage. There's far too much hype. People are getting money shoved down their throats inappropriately. Me being one of them. But I think it's important as well to learn how to be capital efficient from that, and we've learned a lot of lessons from that as well. But yeah, so it was just myself, raised 2.5, and then ultimately hired an engineering team that were, as I said, much better than me at the engineering side of things. So rebuilt the product, added lots of features, and then launched it officially in 2022. So April 2022 was the kind of the official launch date. And the last 3 years, we've scaled it from those 28 sites to over 500. So 500 sites using it, 85% of acute NHS hospitals using the
Mm,
platform. And then there's 40,000 users in the US across places like Stanford, Mass General,
mm.
Boston Children's, a number of others. So it started to scale very well. It's been used millions of times per month, and really solving problems around multiple countries, which is great. And we've really enhanced a lot of the features and the functionality as well, riding that technology wave as such. So
Mm.
obviously this was pre-large language models initially when we were gathering the data. Over the last number of years, we've amassed an enormous amount of a unique data set in the form of institutional knowledge, and we're now able to ultimately build a model that allows natural language querying of all of that data in a specific hospital. And we're doing some really exciting things with that. So we use computer vision and a technique called agentic document extraction. And the reason why we do that is, you imagine about 30% of all of this internal information is in visual context. So it's flow charts.
Huh.
So you imagine that your consultant sitting down, you were anesthetic. So, they sit down and they say, this is the malignant hypertension protocol, and they put a box here, and then they say, if this happens, do this, and they put a box here, and they put a box here. If you try uploading that to a traditional large language model, it comes up with some very interesting answers that are not right.
Quite
So we
dangerous.
use, yeah, quite dangerous. Exactly. Yeah. So we use computer vision to extract that, so it all stays in context, and then build a full RAG-based search pipeline on top of that, so you're able to get an answer that's visually grounded every single time. And that's what we've launched, and that's called Ask Eolas. So we're quite excited about that as well. So yeah, it's been a very exciting trajectory over the last couple of years.
It's an unbelievable amount of scale, but as you say, it's an unbelievable size of problem. It affects absolutely everyone that wants to make a clinical decision, because everyone can just feel a bit better knowing that they have the right information for local guidelines and local protocols and things. What do you think leads to that level of scale and problem solving? Is it purely the fact, well, is it that what metrics are you driving for people? Is it that people are quicker? Is it that there's less mistakes and less litigation? Is it that staff are happier? Because globally, different healthcare systems will value different things. And like we talk about a lot on here, obviously the NHS is ultimately cost. What do we save? For other healthcare systems globally, it's litigation being a big thing. Thinking about places like the US, and wanting to make money and have incentive for staff who can vote with their feet, which they can't do in the UK. They're just told where to go. So there's lots of different incentives here in different healthcare systems. So how do you navigate that globally, and why is this scaling so well? Is it that it's solving all of those problems? In which case, what are they?
Yeah, yeah, great question. So I think the general answers are cheaper, better, faster.
Yeah, yeah.
And how do you measure each
The
of those, and
triple,
what is
yeah.
yeah, the triple, yeah, and what is better? I mean, so a few things we've proven. So we've proven that it's 9 times faster than current systems, and current systems generally are intranet based systems or no system at all, where this knowledge doesn't exist. So that ultimately is a 90% reduction in doctors'
Mm,
time searching for information. So there's a few studies done. Doctors spend about 65 hours per year just searching for this internal information. So their internal institutional knowledge, their clinical guidelines, policies, protocols, etc. And if you zoom that out, and calculate what that cost is the healthcare system, it's roughly around 2 to 5 million per healthcare system, or per hospital per year, of what that actually costs. If you calculate the amount of hours, it's thousands of hours spent just searching
right.
for this information. all of that knowledge should be seamlessly embedded, accessible at the point of care within seconds, and it's not, and that's the problem we solve. So we're able to show a 90% reduction in time spent searching for information, and there's been multiple studies showing that. Another point to that as well is there's a few studies showing that failure to find information. So there's one study that we did. It was a case study that in 20% of cases, doctors couldn't find the out of hospital cardiac arrest protocol when they were tasked to go find it. So one in five couldn't actually find one of the most urgent protocols that you need to access, and yeah, that shouldn't happen. So there's that aspect of efficiency. The other big aspect is governance. So we index all of the policies, procedures, internal guidelines, and we have a full analytics dashboard for that we give back to the hospital system as a whole. So what we're able to say to the hospital is, this is what everyone's searching for. These are the knowledge gaps.
Wow.
Here's
Okay.
where you don't have policies, procedures, guidelines, and this is the search behavior over time. Here's your training needs that might need to be hit. It increases the usage of those protocols that we've shown as well. So increasing the use of evidence-based medicine decreases medical error, increases the quality of care patients can get. So you reduce variability of the care. As well as that, then the downstream effects, if you're this way inclined as a hospital, which a lot of hospitals are as well, which is decreases litigation. So if
Mm.
more people are using the same hymn sheet as such, yeah, you've less variability and less risk for litigation as well. And we're able to prove all of that with regards to the analytics and the insights. We can show exactly who searched for which item at which stage and which time. And those insights are extremely valuable and extremely useful. So they're really the two pillars. Governance is one, and the time and efficiency saving is the other.
It makes me think about your product slightly differently, actually, because what you're talking about is sort of moving from being a service to actually being a partner that helps them improve what they're doing and fill in gaps. That's the difference. You're not just, oh, buy this thing and it allows your staff to search for stuff. There might be some things downstream. That bit that you mentioned in the middle of that story about you're feeding back the gaps in the knowledge because people are searching for this thing a lot more or whatever it is, you're giving real insight back into that entire organization for them to improve in a much deeper way, which turns you from in my mind, that sort of turns you from a service into a partner, but you're kind of aligned with wanting the organization to improve. There's something about that, mate, that's like, for me, I I want health tech companies to do this sort of thing and find incentives to be invested in the improvement of what we're all doing more. I think with things like vibe coding and just attention span and all the rest of it, everyone's looking for shortcuts in things about how do I build this SaaS product that I just sell at 99% gross margins and make loads of money and it doesn't work in healthcare. That approach, that ethos just doesn't work. I think where you've clearly got to is a point of going, we will have to sacrifice some margin here in order to do various things, but that makes us a better partner. It makes us a better business if we can do these things that perhaps aren't as scalable or are a bit more messy. And I think that's important because clearly what you've not done is just gone, I want a SaaS product, I want to copy and paste, and I want to sell this on a subscription model and game over. I'm going to buy my yacht in X amount of years if all this goes well. It's a lot more difficult than that in healthcare, right? So how did you get to that point? And I don't know, like, is it difficult to go in and solve those problems? Is that why nobody presents as a full solution to a problem very often? And it often is these parts of problems being solved by bits of tech. It seems like you're solving more of a whole problem. So, like, can you talk to that a little bit?
Ultimately, what it boils down to is trust. And trust, it takes time, and it takes an understanding of the people that you're working with and what their aims are, and what they want to achieve with a piece of technology or a piece of software or a service, and building trust over time that you genuinely want to solve that problem for them, and that you don't just see them as another customer that you can sell to.
Mm.
And that's built out in lots of different ways, and this ties into the vibe code and everything else. And the reason, when I first started the company, I think one of the principles was, okay, how can we look at every other industry that has a really advanced SaaS product for everything. It's moved extremely fast. It's adopted technology at scale rapidly, and it's created multi-trillion-dollar industries. Why has that not happened in healthcare? Google made a better EHR than Epic, and it was killed. Why does this happen in healthcare? That's really frustrating. That's really annoying. The more you kind of learn, the more you realize, okay, why healthcare does move slowly. And I think the default answer is, because it's dealing with people's lives, etc. But aviation deals with people's lives. Lots of other industries deal with lots of people's lives. So I think that's not only the case. It's the case of, it's a very, very complex system with lots of different stakeholders along a chain. And if you only focus on solving one individual problem for one stakeholder in that entire chain, most likely that problem might be in conflict with another problem that someone higher up the chain wants to solve, or how they have to solve it. So I think there's a large aspect of, you need to be able to solve a problem fast, but you also need to be able to see the system as a whole, and how your solution interacts with that entire system as a whole, and what is the actual true direction of that system as a whole. Um, and as well as that, build trust, and while you do that, prove the clinical safety out of it. Engage with the regulators as and when you need to, if your product needs regulation. So building all of that trust is really, really important. But I would say having a good visibility of where you fit in the system as a whole. We chatted we chatted before we jumped on here. We chatted about main character syndrome, and I think people that want to build a product say, I'm going to completely change the world, and this product's going to change the world forever. And yes, products do that, and technology is deflationary, and it lowers the cost of care, increases the access, etc. All of that. But it's one product in a suite of everything else that's happening in a complex healthcare ecosystem. And you can't be arrogant enough to think that your solution is going to be the absolute pinnacle and the solution to all of healthcare's problems. It's going to be a solution and a problem, but you have to understand where that fits in with everyone else's problem and solution as well. And I think being sensible and being pragmatic and understanding that is a really important part of the journey. I would say that's a decent answer. There's a Japanese phrase that is lost to me now, but it's something basically like, the beginner mind has the most open mind, as in, once you start, there's the possibilities are absolutely endless, but there's a naivety with that mindset. And healthcare is a perfect example of that's not what's going to happen in the real world. There's too many moving parts, and there's too many stakeholders, and it's too complex. So you have to find the problem and understand where that problem fits in the wider problem set of healthcare in general. So yeah, that's a very long-winded answer to say, find out where you fit in the wider ecosystem.
How did you build that trust initially with people? Is it because you worked in the hospital where you were trying to solve the problem, so that the trust was already there? And how did that scale? Did you have to go in as a human being and build that trust yourself before people trusted the product?
Yeah, so I think being a clinician definitely helps. Being a clinician is a double-edged sword in this, especially at the early stages of the company. One aspect is of, okay, this is a doctor, they've experienced a problem, they developed a solution, and 28 hospitals using it. Okay, there might be something here, we have this problem too.
Mm,
So they trust the social proof, they trust that you've experienced the problem, and they like the fact that a doctor's solving that problem.
mm.
The flip side of that is, okay, you're a doctor that worked in the NHS for 5 years. What do you know about running a business, or commercial, or scale, or product, or technology? And you have to be able to then prove that out as quickly as possible. The only way you really prove that is solve that person's problem. And once you prove you can solve that person's problem, more people see that, and get that social proof. I would say, like, if anyone's starting on the start of that journey, have a look at the innovators adoption curve, or the technology adoption curve. You want to get the innovators, you want to get the early adopters, you want to identify how to cross the chasm to the early majority and then the late majority, but it's hyper focusing on those people that are going to get the social proof. And that's what builds trust. The initial trust is, yeah, your clinician. The second bit trust is, okay, yeah, lots of hospitals then trust this, and then that allows you to cross the chasm into the wider
Mm.
kind of community.
I just want to tell a quick story about how I really craved this, what you're talking about, because I can remember when I was in A&E, I was on a shift. I can literally picture this because it still haunts me. I saw a guy who had a swollen arm. It looked like he had an insect bite. He was gardening and he got some sort of bite on the forearm, and he was getting really quick spreading redness, heat, all the classic stuff of, like a quite fast spreading cellulitis. Obviously, for people that aren't medical, it's like an infection under the skin. And the one thing you're always taught in medicine is to be careful of necrotizing fasciitis. That's the one thing when you see anything like this, always has to be on your mind. You've got to rule this out. So if it's rapid spreading, if it's all these different criteria of what would meet it, then it really activates something. I was given advice that it wasn't that. And I'd written in the notes that it was rapid, and I'd drawn it and I timed like how fast it, and I'd written these things, so I'd given advice, and okay, like I'm still not sure. So immediately I'm like, now I need like, can I just have like a list of things that I can tick off and put in here to go like, okay, I think this is because, and I can do that to some extent, but for whatever reason, when I took advice, that wasn't the case. But then I was asked to draw up a load of, I was asked to find out, actually, I was asked to find out how to discharge this person with IV antibiotics, and then someone to go and visit them at home in order to check it, and like a district nurse to check it, and all these things. And it was an A&E I was not au fait with. I didn't work in this A&E. So now I've got loads of problems now. I'm worried for me. I'm worried for the patient. I've got to do this thing that I'm not sure about how to do it. And there was so much about how they wanted this specifically, that they do this thing here where you can be discharged with antibiotics and a district nurse will go and see you. Well, I haven't got a clue about that. I don't know how to set that up here. I don't know anything about it. And I'm trying to ask people, and it's a really busy A&E shift. I'm a locum there, so they need locum support, so they're not well staffed anyway. Anyone that I can really ask about this problem is tied up. And so I just feel so alone. I feel so lost. I'm still so junior, man. Like I'm 2 years into my medical career. Like I just feel lost in this moment that I've not got the information to work with. And I can feel almost like a physical weight on my chest that there is risk all over the place here. And I just feel awful. And if this could have taken that away, so I would be eternally grateful to them if they were to buy this, because I know that there are clinicians every single day that are listening that will feel something along those lines. So in your model, I guess I can just free text, ask a question. Hey, what do I do? I've been asked to discharge this person with IV antibiotics and something about a district nurse. How do I set this up? And it just returns me the answer.
Yeah, exactly. So I think the big problem is not knowing where a policy is. I think if you think
Yeah.
I'm going to go to SharePoint or intranet, do we even have a policy? Where do I even go? You're searching through all of these files and folders, etc. So you either do have a policy and you can't find it, or you don't have a policy at all. And how we help with both those scenarios is you literally just take the phone out or you go to the desktop, ask the question, get an answer, and it says, "Yeah, here's the policy. This is the pathway. This is exactly what you do."
Right.
If you don't have the answers to that, either from a tacit knowledge point of view or an official codified knowledge, and I can chat about the difference between those two, that query and will then be fed back to the leader of the department as well as the hospital's leaders as well, to show
Wow.
here are the queries that are happening every single week, every day, every month. And we then can aggregate those queries into common themes. People are constantly searching about OPAT or outpatient antibiotic therapy. Why do they not know that we have this service? This is how
Mm,
this actually works. We should probably put something on the platform about that so they can get that information. The some of the time, a lot of the time, this information mightn't actually exist, so it mightn't be codified into a policy or procedure or guideline, etc. So what we also do is allow crowdsourcing of tacit knowledge. So tacit knowledge is in the fact of, it's Friday, it's 7 p.m. The radiologist is away home. How do I get an MRI spine? I think this is called Aquina.
oh,
Like, what
this is
actually do I
so
do?
real. Yeah, I love
Um,
this.
so
Okay.
so how do you get that? Generally, you then find one of your colleagues that knows that answer. You
Yeah.
ask one, they don't really know. One colleague might know, and they go, "This is what you do." So in the app, we collect that information as well. So you can just ask a question. How do I get a scan? Hey, here's an answer that was given. If you're able to do that. So it's the two types of internal knowledge are either tacit, all of that kind of nitty gritty, wiki type knowledge that only people have in their heads, as well as in the official knowledge that exists. So that's kind of how we solve that problem across that
Mm,
spectrum. The really powerful thing that we're super excited about is the democratization and access to that content for new sites that sign up. What we're creating is network effects in the platform where when a new department signs up, it becomes more valuable to the next department that signs up. And how we actually do that is We're building a feature that allows, once you sign up, when you have an empty space, you'll be able to scan your policies and say, hey, here's the gaps in your policies based on what multiple other sites think
Ha!
is the best treatment.
Wow.
And we can also then sync that with NICE guidelines, national guidelines, and say, hey,
Right.
here's what the national policies are as well. Fill in these and then automatically do that. 5 years ago, that was a manual task that needed
Yeah.
clinicians. Now that's a perfect use case for generative AI with a human in the loop to approve or disapprove. So there's so much potential then downstream of this to be able to ensure everyone can access that when they need it.
It's funny where we are with AI in healthcare because what you're talking about in terms of knowledge management, decision support goes very wide, um, but knowledge management specifically, it's kind of it's a it's a late presentation of what AI can do when you consider that we started with the radiology stuff, we've had the ambient scribe stuff. Where do you think we are broadly with AI and our comfort in healthcare? And where do you think we're going to be in the near future, particularly around obviously the area that you're involved in? And again, the reason I ask the question is because I think it's important that we, as the health tech community, don't use a generic term like AI and just build assumptions around it. There are distinctive types of AI. We've had eras of AI doing specific things and different things that we should be comfortable in differentiating. So I'm interested in how you see the world, where Eolas fits in, and where we as a health tech community and Eolas specifically might be moving when it comes to AI. And feel free to be quite specific in your terminology.
No, 100%. I think it's a great question. And I think um, generally there's a pattern. There is a new technology and there's a technology shift. Then there's a disruption where everyone's freaking out and losing their minds. Then there is the phase of, and this is such a nerdy answer, no one's going to get this reference, but there's the phase of the board is set, the pieces are moving. This is a Gandalf quote from Lord of the Rings. And then there's the adoption phase of that software. So if I use a few different examples here, so if we look at each of the kind of waves of AI that's coming and really made a difference in healthcare, the first big one is visual based AI, so convolutional neural networks for radiology.
Yeah.
Detecting fractures, detecting stroke is probably the two biggest ones, but there's lots of other use cases. Um, there's a fairly ubiquitous adoption of stroke detection technologies using AI in the NHS and most other healthcare systems now. Viz.ai was one of the big early ones in the US, but there's now lots of systems that do that. And for anyone that maybe hasn't or doesn't understand the context, they and in general they'll be able to detect a bleed or an ischemic stroke very very quickly. They'll flag it to the radiologist and the emergency department depending on what the operating procedure is, and that flags it a lot earlier. So time to clot retrieval is much lower. So patients benefit. So brilliant use case, perfectly done. So if we imagine, okay, convolution, AlexNet happens, convolutional neural nets hit the world. Lots of other industries are using it, like self-driving cars, etc. Healthcare is like, oh, we can use this too, and then it's like, oh, we're going to use AI to diagnose a stroke. Emotional reaction, the world loses its mind. No, that can never happen. We're not using this. This is too unsafe. Here's everything that's going to go wrong. Da 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 da. Really important reaction. It's really important to see where these can go wrong and where they'll actually work. What happens then is everyone starts to understand the technology. Everyone starts to have some aspect of using it to an extent. And then it starts to get regulated to an extent as well. Depending on the geography, that happens at different paces. And it then gets a clearer picture. And two things happen. One, the technology accelerates to how good it is, and then it kind of plateaus, and that's where then it gets better and better and better every year. But people get a sense of, okay, what this can do and what it's going to be able to do in a year or two. Once it explodes onto the scene, everyone's like, wow, what's this going to do in 5 years if it's doing this now? This is going to change the world forever. And it's like, no, it's going to change this small aspect of the world forever, and it's not going to change the world forever, and this is how it's going to work. So regulators regulate it. Companies, the market answers. Companies are spun up. They know how to use it. They use it. They engage with the regulators in an appropriate way. They prove out the clinical safety and efficacy. They launch the platform. They prove the health economics of it, and then it goes live. Brilliant. That's great. Same thing then happened with ambient listeners. So you have then this new wave. So large language models hit the scene, transformers. Based on the same underlying architecture. Ultimately, when you bound down to, but it's new transformers. Everybody loses their mind. This is artificial general intelligence. This is going to be horrible. Healthcare can never adopt it. It's going to take all of our jobs. Da da
Is
da
it
da da da.
sentient? Da, 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 da.
And then exactly as a sentient data.
I've
And then
said all
what
of this, by
happens
the way.
is,
I've said all of this on here, so yeah,
oh,
I'm
yeah,
very
okay,
willing
yeah, so
to take the mick
yeah,
out
yeah.
myself here for
Uh,
very much riding these waves.
Yeah, yeah. I know it's really important as well, though, to come up with the excitement because they do solve big problems. But so it goes on to the scene, and 2022, 2023, it was like, how do we even build using this? Like, if I build a model now, or if I build a RAG-based search, or what I do, is there going to be a new model tomorrow that comes
Yeah.
out and just completely destroys this business model or completely destroys this product? But now what we're seeing is this kind of plateauing. The models are getting better and better, but there's not of this exponential
Yeah.
shift. So that's what I mean is now the board is set and the pieces on the board are moving. So what it allows you to do is actually now play a game. Okay, what's the game? How do we solve a problem with this? How do we regulate this? How do we get this into the hands of people safely? So, over the last year or two, no one's going to use this. No one's going to use voice AI because it's too unsafe. What if it hallucinates? Da 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 da. Prove out the clinical safety, engage with the regulators in the UK. In the case, this is either going to be a class one, it is now a class one, it probably will start to move down to class two. And then hospitals are like, wait a minute, this will improve a lot of our efficiency, et cetera, et cetera, et cetera. Let's build this out. Large language models will not get us artificial general intelligence. That's not going to happen. We will get AGI at some stage. They will be a part of it. There will be a shift. If we're still using transformers in 5 years' time, we'd probably fail as a species that innovate and do something different. So that's kind of where we are. Part of the subset of the wave of the same technology, i.e., the transformer, is decision support. So one is the aspect of capturing the patient note and then being able to streamline access to that, which improves efficiency. The other is the aspect of how do we then take that note, query a trusted knowledge base, whether it's internal or external, and then send back for that patient in that context. This is the next best step that you should do based on your policies,
Mm.
procedures, and guidelines. So that's the next phase of this. Ambients are some of them are building themselves, some of them are trying to capture the data, some of them are partnering, et cetera, et cetera. So that's really the next phase. MHRA are going to come out, they're going to regulate that space too. That any sort of AI answer engine. So we had, AI for radiology, we have AI for voice, now we have AI answer engines. It's probably the best terminology for them.
Yeah.
So Open Evidence, Doximity's bought Pathway. You have a number of them here in the UK, including Eolas, where ours is called Ask Eolas. So they're, AI answer engines is probably the best name for them, but the market hasn't really named them properly yet. And AVT was named AVT now, or ambient voice, but there will be a name for the answer engines.
Mm.
And that'll be regulated. I think they'll probably come out and say, okay, this minimum has to be a class one, like initially, just to try to get ahead of it.
Mm.
And then they'll definitely say this is a class two or class or either A or B. I think to have true impact at the point of care, you have to engage with that side of it. You have to prove the clinical safety and you have to get it regulated, because ultimately what you want to do is, out of those 2 billion medical decisions for every patient, how many of them had the world's medical knowledge queried in real time so that it was an informed decision? And to do that, it has to be safe and regulated. So that's kind of the patterns that we kind of come through. I think we're now in a very interesting space where we have a window to be able to build something really big and meaningful. And there'll be a lot of noise, and there'll be continuing a lot of noise. When's the last time you heard noise about convolutional neural networks for stroke detection? But they're every single day are making difference in patients' lives. But it was a very noisy space years ago. So the same thing will happen with this space. People will get bored of talking about ambient listeners and answer engines, and it'll all move on, and there'll be a next thing. And that's important. It allows better care, faster care, safer care. That's a very long-winded answer, but one I'm sticking with.
It's amazing to interview Declan because I've written 6 questions down in the time you've been talking. You've answered all of them, so I actually don't need to. Ask many questions. I can only pop up every quarter of an hour or so. It's amazing. Perfect interviewee. One thing I was going to ask you about actually is your vision for healthcare. Now, I think it's really interesting what you say, that what you're doing, answer engine, might move from class one to class two, and baked into that is obviously this movement from asking a question, it presenting that as an answer, and then the clinician being responsible for the cognition involved in contextualizing that and adding it to the information they already have, what's in front of them, all that stuff. What you're talking about, and it's funny how you're coming at it from this way, and lots of other companies in lots of other areas of health tech will come at it from another way, but moving into this very much decision support to decision making based on the availability of information. And that's obviously the promise that AI has given us, which is, hey, we just need the data. It can be crunched in this model, and then you can just get the right answer, the most evidence-based answer, the most this, the most that. So I'm interested then, because you're a clinician, what do you think healthcare looks like with all of this? What is your version of perfect healthcare, a perfect consultation, the perfect setup? Like where I just wonder if you thought about where this extrapolates to based on what you're doing. What is the kind of utopia based on what you're doing? Is it freeing humans up more? A thing we hear all the time. Is it perfect decision making so that everyone gets the right diagnosis and the right treatment? Is it a mixture of all of that stuff? Where does this go, and what do things look like?
I think it depends on the time frame is the answer. And you said something on this podcast before. I can't remember who you were talking with. What we haven't done as a society, and most geographies, I don't think any geography's done this. We haven't sat down and collectively described what does good look like.
Yeah,
And, we've done we've done a 10-year plan, and we say we're going to adopt all these technologies, etc. And every health system is done to an extent, and they all compete in priorities. But it's no one has sat down to align a vision of what this actually looks like. With regards to kind of what should healthcare look like, I think the way I kind of think about this is, let's zoom out. Okay, in 1,000 years' time, are you going to go to your doctor and see a doctor? Is there going to be an AI? Okay, I think 99% of people will agree it's going to be an AI. In 100 years' time, is it going to be an AI? In 50 years' time, is it going to be an AI? So when you start to kind of bring that in, at what point is it an AI? And is not a doctor? So that's kind of one point. The other point is there will always be doctors. 4,000 years ago, there was doctors. In 4,000 years, there will be doctors. I think one of the fundamental things is humans want to be treated by other humans in whatever
correct.
shape or form that takes, and
Correct.
they're never going to be able to get a holistic treatment of that person if it's not a human involved. Now that human might provide multiple different parts. That could be, in 100 years' time in your house, there is, the Elizabeth Holmes blood test machine. There's some sort of scanner, et cetera, et cetera, et cetera. And the person that's doing the human part could be your partner, and they're forming that part, or it could
Mm,
be something else in a different way. I think the way medicine is practiced is changing, but there always is a human in the loop, and I think there always will be a human in the loop. It's just what that looks like and what time frame that you're talking about. I think if you're talking at a very short and immediate time frame with regards to technologies that are available to us, I think it's very, very conceivable in the next 5 years, if we look at those 2 billion medical decisions that are made, that if you go and see a doctor, in a primary care physician, or if you're in the emergency room, or if you're in theatre, that consultation will be automatically collected. It will query a knowledge base, world's medical knowledge, because doctors and nurses and pharmacists shouldn't be expected to hold this knowledge in their heads. It will automatically give decision support in real time, context specific for that patient, probably based on the patient's genetics, their blood tests, everything else about that patient. And then it will help and act as a proper, true co pilot. And it will more and more get autonomy and make decisions, and the doctor will feed those decisions back to the patient. So I think that's what's happening in the next, 5 to 20 years as such. And it will happen at various different pace.
I'm inclined to agree. And one thing that I've started to notice about our internal use of AI at SomX, or the way that I talk to my friends about how they use it in their careers, in law, in loads of civil servants, there are so many people now that consider AI this co-pilot to knowledge and decision making, that I almost wonder if patients will expect that, and that to not use any sort of support from AI to access the world's historical medical knowledge will be seen as some rebellious form of raw dogging medicine that you've just got a person in a GP surgery that has no internet just giving you decisions, and that's seeming like caveman, cavewoman medicine almost. I just wonder if that's the direction we're going based on what I've seen of my friends and the way they use it. Because if a lawyer is using Harvey or whatever their equivalent is to access all available case history in the library to find precedent for an argument in a court of law, then surely when they go and get investigated for a potential rare disease, they're going to expect the equivalent. They're going to expect the case history of all cases similar in medicine to be searched to figure out what their differential diagnosis in order of prevalence. That's what I would almost assume if the world is using AI in such a way, they might then expect, and you might then get this bottom up demand. I've got no evidence for this. It's just sort of a thought that I have that something like what you do, or literally what you do, will become an expectation. It will become the norm. It has to, because I imagine you don't churn many clients, if any.
Yeah, yeah, no, minimal, yeah.
Yeah, right. Because I imagine this is something that once it's there is nigh on impossible to go back from, just because of the importance of it. I just wonder. I just wonder.
I think the biggest trend there is that's happening now is the consumerization of healthcare. I think because health systems globally, especially the NHS, but lots of other health systems globally are under so much pressure. You know, the aging population, you have long wait times, etc. All of that. You're now seeing the consumers taking their and the patients taking the healthcare into their own hands.
Yeah.
And if they're, you know, yeah, I think it had its chat GPT moment. Dr. Google was, you know, obviously a big thing, and is a big thing, and 30% of all Google searches are health related. Something like 45% of all chat GPT queries are health related. And if you're going and getting an answer from the world's medical knowledge, you know, at this stage, from this, and you're going to your doctor and they don't know what you're talking about, because the world's medical knowledge, 20 every 26 seconds there's a new study published, and like of course someone's not going to know that. I think another really important aspect is looking forward. People, I think it's a really important point is ChatGPT currently, or you know, whatever platform you're using, whatever maybe what the consumers are using, this is the worst it's ever gonna be. You
Yeah.
know, this
I
is
think
the
about
most
this loads.
unsafe it's ever gonna be, and it's gonna be better every single year, and it's a case of the future is here, it's just not evenly distributed, and how you get that even distribution is you engage with clinical safety, you get it regulated properly, you put it into the systems that kinda currently exist, and you get it distributed to the patients at the point of care. There was a study done last year. There's two comparative studies. It was taking patient expectations, and I'd probably misquote some of the figures, but it's more about the delta and the difference in the figures. The Initially a few years ago it was asked, would you be happy if AI was used in your care, in the course of your care? And this was maybe about 5 years ago, and about 10 to 15% of patients says yes, I'd be happy. And there was a more recent one done last year that showed that asked, do you expect AI to be used in your care? And 65% of them answered, we expected AI to
Right.
actually be used by our doctor at some point, even if we weren't aware of it, even if it was
Right.
triaging blood tests or something like that. So in the space of a couple of years,
Mm.
the patient's sentiment has rapidly shifted. So yeah, it's definitely the trend that's happening.
Yeah, which does sort of prove the hypothesis, I guess, in some way. I do expect that trend to continue. I really do. I'm interested, Declan, before I let you go, in terms of that future and getting there and where Olus fits into it. What are the biggest threats to you that you perceive at the moment? Threats to Olus, I mean, um, in terms of its potential progress or its success. Where do you think this where do you think this lives or dies?
I think regulation is a big is not just the oldest, but this decision support space in general,
Sure.
and the ambient listening space prior to this. I think how we handle as a society how AI is deployed, and how it's regulated,
Mm.
and I think there is a real risk that we go far too heavy-handed with it in the EU and the UK. I think the UK is pulling back to an extent, and I think it's very clear that the NHS has made it clear that that AI is, is going to be the savior as such. The technology
Mm,
itself is going to increase efficiencies, etc. And I think it will have a part to play. So it's good to hear that's the sentiment. It does need to be regulated. It does need to be safe, but it needs to be allowed to be used in a way that is safe and regulated. If you neuter this technology, we won't get the GDP growth that it needs to drive,
interesting.
and we'll all enter a massive recession, and we won't get the benefits from healthcare that needs to be derived from it as well. So I think that's the biggest risk that we have, and there's a divergence in geographies of how each geography is adopting this as well. The US is allowing, it's a bit more Wild Westy. It's allowing things to be used at the point of care a lot more. There's a lot of talk in the US with regards to regulation around model size, around how do we regulate it, around output, around size of the company, etc. And I think we can't neuter the potential of this technology. We have to get the balance of safety. We have to get the balance of the people actually trust it, but we can't just we can't neuter it. Imagine if you said, "Yeah, okay, here's the internet," and in the 2000s it was starting to boom, and everyone said, "Oh no, but you're only allowed to use it for 10 minutes a day." I think
Mm.
we have to get that balance. We have to wrap laws around it, and it's a really difficult task for regulators. It's a really difficult task for governments to try to navigate that. And it's good that they've shown that they're able to change, and when they get things wrong, or move fast when they get things right. I think that's the single biggest risk. If say for example MHRA came out and said, okay, you're not allowed to use AI for automated decision support, or not allowed to use large language models because you can't prove the software of unknown provenance in there. You can't actually prove out the exact pathways where you got that decision. Therefore, it's never allowed to be used. Now, I don't think that's going to happen,
Mm.
but I think there's a risk that it neuters it to the point where you're only allowed to do something, and it actually the utility value significantly decreases. So I think that's probably the biggest risk in general.
Heidi have just done their 65 million Series B. They're talking about this AI care partner on the full administrative side. So moving very much out of the pure AI scribes to cover more of admin. Where do you think do you think companies like that will end up trying to swallow up the areas that you're in and take over that sort of stuff? And is that a potential sort of almost exit strategy for you, that there's this big consolidation of these like emerging beasts, or you going the other way, you acquiring them if you're doing a Series B, etc. Or a consolidation where it's a partnership? Like, what do you see that happening, where there are like these really big behemoth players, or do you see everyone sticking to their lane and building out partnerships together, and you going, okay, well, Heidi go all the way up to there, or Tortoise or Tandem or any of the others, they go all the way up to this bit, and then there's a bit of a gap and we do this bit, so maybe we could work together on the bit in the middle. Like, how do you perceive those companies and where you sit?
I'd said this before on a different podcast, and you may have seen it or not, around this idea of bundling and unbundling of
Yeah.
healthcare software. Yeah, so 5 years ago, electronic record, single point, technology shift, and there's lots of demand for that new technology. The EHRs or other systems don't offer it, so then you get explosions in ambient listeners and AI for radiology, etc., etc. Then you get a rebundling, so the EHR starts to try to gobble as much of that workflow as possible. I think it's really important that there isn't multiple disparate systems, and doctor has to use 50 different
Mm,
systems. But it's also important that if they're using one system, that it's using the latest technologies and it's actually solving problems. So there's always this constant tension between how many systems versus does the one system actually solve the problem. One system will never solve the problem, so there will always be this kind of partnership. Where does Olus fit into that, and how do we move? I suppose is the direct question. One aspect is managing internal hospital and institutional knowledge is a very different problem to solve than translating and transcribing a clinical note at the point of care when it's been taken. So they're two very, very different problems, and it affects two different people. Internally in the hospital, it's the clinical guideline team and the governance team, or the pharmacy team around the medicines, and it's a lot of the doctors that are leading this policy side. So solving their problem, proving clinical governance, proving that that's safe. Then when you take that downstream of, I want to get a decision from that policy automated using AI, that's a class 2 device. So then
yeah.
you have to go down and prove all of that out. So doing
Yeah.
all of that is what needs to be done in this knowledge management space. If an ambient listener, because I know they probably are going to do that, and there's a number of them are starting to look at doing
Mm,
that, but they have to solve the problem of, how do we do all the transcription? How do we regulate that as a medical device? Then as a separate problem, they have to then go and solve all of the problem with regards to knowledge base, et cetera, et cetera. Ultimately, if in we're probably one of the world's largest collections of internal institutional medical knowledge that exists
Mm.
currently. Certainly in the next 2 to 3 years, we'll be the single largest internal repository across multiple hospitals.
Wow.
Is it easier to just API with that? Or is it easier to reconvince everyone to upload all of your content to our new system that we haven't proven yet? So we built an Eolas Medical API. So any
Right.
ambient listener, so we already built an API. So
Right.
any ambient listener, any electronic record can make a query with an anonymized note, send it to the Eolas knowledge base, and in real time we can send back, hey, for that patient, this is the thing that you need to do, and they can render that in their system the way they want to. I think that's where it goes. It probably APIs. 10 years down the line or 5 years down the line, one of the massive behemoth players or an electronic record, is it easier then to buy all of that data and that distribution because it doesn't exist anywhere else? Probably. So that's that's probably what will happen. If we look at the external content that a doctor needs, that's commoditized. You're going to be able to access that from everywhere. So buying that content isn't very useful because there's no defensibility. Getting access to a knowledge base that's the world's largest internal repository of medical knowledge that exists on the planet, that's very valuable to either API and sync with or to acquire. So that, I'd say that's probably the path that this goes
Mm.
on. But it's always back to what's the focus. The focus is making sure the problem solved for the patient. Those 2 billion decisions, did the world's medical knowledge get queried? And that's kind of what our focus is. And the more people that are
Mm.
doing that, the better. And if we can partner with someone eventually down the line and make an acquisition so that we're continuing on that path to make sure
Yeah.
that all of those billions of decisions are being informed, then that's something we'll probably look at as
Very
well.
interesting. Very interesting. When's the next funding round? We've got a lot of investors listen to this. They always tend to reach out to people that have come on. But yeah, are you interested in chatting to them? When's your next round?
There'll be announcements coming soon.
Right, right, right.
So
Okay.
yeah, so essentially, we're in the middle of an oversubscribed round,
Right.
and we're navigating that at present. So we're in the middle of an oversubscribed Series A.
Mm. Could take it all and then start buying people up. That's it's always an option. It's always an option.
There'll be a lot of that. I think there'll be a lot of that in the next 2 years.
Declan, this has been awesome. I've definitely learned so much from you here. If people want to learn more about Olus or get in touch with you, what's the best way for them to do so?
Probably LinkedIn is probably the easiest way to reach us. Send me a direct message, connect with me. More than happy to talk to anybody. So just send me a message on LinkedIn.
Amazing. We'll put the link to your LinkedIn in the show notes. Absolute pleasure, man. Thank you.
Amazing. Cheers, James.